Hi, I'm Professor Ben, and today we're going to walk through an incredibly high yield topic for nursing pharmacology, and that's pain medications. But I'm structuring this voiceover lecture a little bit different than most pharmacology lecture. Rather than memorizing a long list of drugs, I'm going to walk you through how nurses make safe medication decisions for pain management. By the end of the day, I want you to look at the patient and confidently answer three questions. First, what medication is appropriate? Second, how should I assess it, the patient, before giving it? And third, what complications am I watching for? For those new to my teaching style, I like to open each narrative module with a clinical vignette. So let's meet Miss Jones. She's 67 years old and she's recovering from a total knee replacement on the local med surg unit. Her reported pain is a 6 out of 10. Her provider has ordered acetaminophen, ibuprofen, and morphine, PRN, or as needed. As you review her chart as the nurse, you notice three important things. First, she has stage 4 chronic kidney disease. Second, she has a history of asthma. And third, she has a history of a previous gastrointestinal bleed. I want you to pause for a moment. You can pause the recording. I'll be right here. Ask yourself which of these three medications concerns you the most. Don't worry if you're not sure. We'll return to Mrs. Jones throughout today's lesson, but our goal as nurses is to always practice with patient safety as our foremost goal. So rather than trying to memorize a dozen of different medications today, I want to focus on a handful of ideas and some high yield medications that should have an enormous impact on safe nursing practice around pain medications. So by the end of this lesson, you should be able to recognize different types of pain, understand why major medication classes work, identify situations where those medications may become dangerous, and explain the essential patient teaching that keeps your patient safe. Most importantly, I want you to begin developing the habit of asking yourself, what should I assess before giving this medication? That simple question prevents countless medication errors. Before we choose a medication, it helps to understand that pain is a process. Tissue injury first creates a signal, and that signal travels to the spinal cord and brain. And as the brain perceives that pain, it travels through the nervous system, both up and down. Different medications work at different points along this pathway. And you don't need to memorize every step of the detail, but just use this pathway to predict how a medication works. So we have transduction, which is the tissue injury activates nociceptors, which creates a pain signal. We have transmission, and that's the signal traveling through the peripheral nerves and the spinal cord towards the brain. We have perception, which is where the brain recognizes and interprets the experience as pain. And then we have modulation, which is the nervous system, which is increasing or decreasing the strength of the pain signal. Before we can choose the right kind of pain medication, we need to ask what kind of pain we're treating. Are we looking at a swollen postoperative knee, a burning diabetic foot, a chronic low back pain? They could all be rated 8 out of 10, but that doesn't mean they should all receive the same type of medication. So what's causing the pain? How long has that pain been occurring? So first we want to identify the type of pain. We know that tissue pain is mostly related to nociceptive receptors being activated. Inflammation tends to be an inflammatory process and have an inflammatory pain. Due to swelling. Nerve pain tends to be related to neuropathy, or persistent pain tends to be chronic. And as we ask our patient these questions, we can use the OPQRST that we all learned in assessments to assess their pain and kind of get an idea of the type of pain that they're having. And that can give us some clinical clues on what type of medication might be the most appropriate, especially when we're faced with a group of PRN orders. So let me just show you this little chart here for you. So nociceptive pain is where tissue activates pain receptors. We'll talk about that a little bit more. And that's that kind of achy, throbbing, sharp pain. And when you have that, you might think analgesics. You have inflammatory pain. So that's the tissue injury, the inflammatory mediators like COX-2. We'll talk about that in a minute. And you might have pain that feels like it's swollen, or warm, tender. And those are going to probably be best treated with nonsteroidal anti-inflammatories or NSAIDs and steroids. Then you might have damaged abdominal or damaged or abnormal nerves with neuropathic pain. And that'll be burning, shooting, tingling, electric kind of pain descriptors. And that might be something like a gabapentin or a duloxetine. And then you might have chronic pain, which is pain that persists beyond expected healing. So that might be like 3 months after an injury. And that might involve multiple different types of mechanism. And typically a response to that might be multimodal. And we're going to cover these various types of pain interventions in this lecture. So let's first organize our thinking, starting with the brain and moving down on where pain medications work, because that gives us an idea on how these medications can work. And we'll dig into these in just a bit, but let's start with a high-level overview. For starting in the brain and the central nervous system, that's the ultimate recipient of the pain. Opioids change how pain signals are transmitted and perceived within the brain and spinal cord, and how those pain signals are transmitted and perceived. Acetaminophen mainly reduces pain and fever in the central nervous system. Then if we move to the spinal cord, we have gabapentins and opioids that affect signal intensity and the transmission of the pain. And then when we move down to the local level, we have NSAIDs that block COX enzymes, which block prostaglandins, reducing swelling and inflammation. And we have steroids that act at the site of the injury. And once you know how these pain medications work, or where they work and how they work, the side effects begin to make some sense. Pain is actually a protective mechanism, and before we can understand medications, we first need to understand what they're trying to change. Pain doesn't occur by accident. It's one of the body's most important protective mechanisms. Imagine that you accidentally touch a hot stove, and pain immediately tells your brain, hey, move your hand, right? That's a good thing. We want to move our hands. We don't continue to get tissue damage, right? But what's happening? This particular pathway isn't the same pathway behind every type of pain, but it is one important pathway by which tissue injury and inflammation activate and sensitize pain receptor. And it's the pathway for NSAIDs that we're going to look at here in just a moment. So we have cellular injuries or tissue injuries which release arachidonic acid. Fun fact, arachidonic acid is similar to like an omega-3 type of fatty acid, which is why omega-3 fatty acids help treat inflammation. Total side note for you who like to geek out on random pharmacology knowledge. So you have a tissue injury which leads to a release of arachidonic acid, and that releases COX enzymes. These COX enzymes then release prostaglandins. The prostaglandins create inflammation and they sensitize those nociceptors, and which we result in pain and inflammation. And this can be helpful. It's the body's way of saying, hey, buddy, pay attention over here. But what the body can do, it can also overdo. But it's also to note that prostaglandins are also chemicals that help our bodies too. Not only do they cause the swelling, the heat, and the pain that make our patients miserable, they do some good things like protect our stomach lining, supporting our kidney function, promote blood clotting. And different medications interrupt this pathway at different points. And so once you understand the pathway, you'll be able to understand and predict how these pain medications work and certain adverse effects. Our body uses two main paths to make prostaglandins, COX-1 and COX-2. I want you to think of COX-1 as the housekeeper. It's universally present. It protects the gastric mucosa, promotes platelet aggregation, supports renal blood flow, protecting the kidneys. And I want you to think of COX-2 as the fire alarm. And it goes off during inflammation and tissue injury. And so here's our clinical decision that we make as nurses. How do we stop the pain and the swelling that is created by COX-2 without accidentally firing the housekeeper that's keeping everything working well, which is COX-1? So let's meet our first drug prototype. Before we do that, let's just stop for a moment. Without looking back at your notes, I want you to answer this question. Which medication class or classes actually reduce inflammation? You can pause the recording if you want. The answer are NSAIDs and corticosteroids. Acetaminophen and opioids reduce pain, but they don't treat inflammation itself. And that distinction becomes really important when you're choosing the right medication for the right patient. And how about this one? Which COX enzyme, COX-1 or COX-2, is responsible for inflammation? Well, the answer is COX-2, the fire alarm. Think of two alarm fire with two little flames on there. So when you think COX-2, or you're thinking pain and swelling and heat and all those things related to inflammation, I want you to think of a two-alarm fire. And that's produced at the injury sites. It drives the pain and swelling, heat, and fever. And so what is the one that is responsible for protecting gastric mucosa? And that's COX-1. That's the housekeeper. That's the one that protects the gastric tract, that promotes platelet aggregation and supports renal blood flow. So let's take a look at ibuprofen. Ibuprofen successfully stops the fire, which is COX-2. And that means that soccer player's ankle that goes down, they take it, the pain stops. But it also is a type of medication that blocks the housekeeper, COX-1. And then that patient completely loses their ability for their stomach to have a protective mucus layer, and blood flow to the kidney drops. And so the functional mechanism is directly related to our danger zone. So let's take a look at ibuprofen. It's a non-steroidal anti-inflammatory. It's a non-selective COX inhibitor, meaning it blocks both COX-1 and COX-2. And because it blocks COX-1 and not just COX-2, there are major risks such as GI bleeding, kidney injury, or bronchospasms in susceptible patients. There are some different medications that are similar to ibuprofen, like naproxen and ketorolac. I give a ton of ketorolac every day when I'm in the ER. And this medication, it decreases pain, it decreases fever, reduces local inflammation because it's blocking that COX-2, but it also blocks COX-1. So how do NSAIDs work? Well, they work by blocking the cyclooxygenase enzyme, or COX enzyme. COX enzymes help the body produce prostaglandins, which are the chemical messengers that contribute to inflammation, pain, and fever. So when ibuprofen blocks COX, the body produces fewer prostaglandin, and the result is less inflammation, less pain, and lower fever. But there's an important nursing connections. Even though prostaglandins aren't all bad, when we block all of them, like we do with a non-steroidal inflammatory like ibuprofen, we lose the protection that they have for the kidneys and for the stomach. And so the same mechanism that makes them effective also explains some of their biggest risks. They block COX-1, and that decreases prostaglandins that are our protective prostaglandins, in addition to the ones that cause inflammation. So let's look at a priority assessment before we give them. We want Before we give a medication, we want to ask ourselves some different questions. Does this patient have a history of kidney disease? Do they have a history of stomach ulcers or GI bleeding? Do they have heart failure, pregnancy, asthma that worsens with NSAIDs? Your assessment often determines on whether or not this medication is appropriate before the patient ever receives it. And one of those questions is to screen for active ulcer disease, bleeding disorder, or severe chronic kidney disease. For example, if a patient has really poor kidney function, it's probably not a great idea to give them a massive amount of ketorolac. That could damage their kidneys. It's also one of the reasons why we ask a question before we give ketorolac, which is basically a souped up form of ibuprofen. I tell people that imagine if Arnold Schwarzenegger and ibuprofen had got together and had a love child, that would be ketorolac. It's like super strong, but it also pounds the kidneys pretty hard. And so we want to be sure that they haven't had any ibuprofen or naproxen or any other NSAID prior to coming into the emergency room for at least 6 hours. We also want to continue to assess them during and after. We want to monitor blood urea nitrogen levels or BUN levels, as well as serum creatinine. We want to assess for dark tarry stools or melena or coffee ground emesis, and those are indications of GI bleeding or problems with renal perfusion. So we do have some NSAID dangers here again, and we just keep talking about these repeatedly, and that's gastrointestinal effects, and we have kidney or renal effects there. The important thing to note is that NSAIDs relieve inflammation, but prostaglandins also protect things like kidney and blood flow. So let's look at some patient teaching. So with non-steroidal anti-inflammatory drugs, we want to take them with food or with milk. It doesn't reduce the risk of GI bleeding as much as it just helps with stomach upset. We want to avoid concurrent alcohol use or taking multiple types of NSAID simultaneously. We don't want to take we don't want to OD that pounding of the kidneys. We want to stay well hydrated, and we want to avoid prolonged self-treatment with medical guidance. Sometimes people think that just because a medication is over the counter that it's completely safe and without risk. That's not true. There are risks with over-the-counter medications. So let's talk a little bit about some NSAID outliers. I did mention a couple of them here. One is ketorolac or Toradol. This is that highly potent love child of ibuprofen and Arnold Schwarzenegger. You don't want to give this one for more than 5 days due to a risk of renal failure and GI perforation. So this is not one to be given long-term. Another one that you might see is celecoxib or Celebrex. It's a selective COX-2 inhibitor. It decreases the inflammation while having less COX-1 inhibition. Remember, COX-1 is the protector. COX-2 is that two-alarm fire. That's the one that causes inflammation. And so if it can reduce the risk of GI complications compared to non-selective NSAIDs like ibuprofen. But that risk isn't totally eliminated. There's also cardiovascular and thrombus risk that's related. So just a quick little visual here. So COX-2 reduces GI irritation. You can use it longer term, but it has an increased cardiovascular risk warning. Where ketorolac, it's short term. Don't use it for more than 5 days. And the acute is really focused on acute pain, if that makes sense. So aspirin is also an NSAID. It's an unusual one. It's a non-selective COX-1 and COX-2 inhibitor, but it's also an antiplatelet medication. So we covered this a little bit in our cardiology section. It irreversibly binds to platelets to prevent blood clots while blocking COX-1 for the life of the platelet, which is 7 to 10 days. So that can increase bleeding risk. You don't want to give aspirin to children with flu symptoms because it increases the risk of Reye's syndrome. And finally, you want to watch for tinnitus, which is a ringing in the ears, which is a sign of overdose. Let's move to acetaminophen. This is not an NSAID. Acetaminophen is its own little thing. It doesn't care about peripheral issues. It travels straight to the brain, and it blocks prostaglandin centrally to lower fever and stop pain. And unlike NSAIDs, therapeutic acetaminophen does not reduce renal blood flow through the peripheral COX inhibition. It makes it generally safer for patients like Sally who have kidney disease, but we still need to dose her appropriately. Because it doesn't touch the peripheral COX-1 or COX-2, it doesn't cause GI bleed in the same way, and it doesn't stop platelets from aggregating. But it does have a fatal flaw, and it's a fatal flaw. It's metabolized exclusively by the liver, like a lot of medications, but it can lead to liver toxicity and death. So acetaminophen, it's like Tylenol. Its functional mechanism, it acts primarily through the central nervous system to reduce pain and fever. How it works, it's still a mystery. There's a crucial decision here. It's only an analgesic for pain and an antipruritic. So it only treats pain and fever. It doesn't have any anti-inflammatory processes. So it doesn't work on pain related to tissue swelling. I mean, it'll work on the pain, but it won't stop the swelling. So in clinical decision context here is it's useful for dull central pain like headaches or fever, but it's not great for acute sprains or arthritis in terms of treating swelling, though it can help block the pain that is related to swelling. And we want to be cautious of its metabolism by the liver. So as far as dangers, acetaminophen, you don't want to, even a healthy patient, you don't want to give them any more than 4 grams max in a day because it's hepatotoxic and it can lead to irreversible hepatic necrosis. There's that really strict ceiling. It's 4,000 milligrams per day for 24 hours, and that's a great NCLEX question. They will ask you about that potentially. It's also a safety thing to know. Your priority nursing assessment here is going to be monitored liver function tests like AST and ALT. And you also want to cross-reference over-the-counter multi-symptom cold medications to prevent accidental hidden toxicity. And here's an example of that. So let's say someone's got a headache because they've got like a flu bug, and so they're taking Tylenol, and it says, take 2 Tylenol every 4 hours is needed for pain. So they do, or maybe they even overdo a little bit, but they're also taking like Tylenol cold and flu, not realizing that there's acetaminophen in there, and they come in with liver failure and are wondering why. It's because they nuked their liver. The antidote for this is N-acetylcysteine or NAC, but it has to be given like right away. So it's a dangerous thing and a good place to do some education for your patients. So let's revisit Sally Jones. We learned in our assessment that she has stage 4 kidney disease. So which of these non-opioid options appear safer for Sally? And given her stage 4 kidney disease and a previous GI bleed, acetaminophen avoids those major NSAID concerns that we're seeing. But we still need to check her total daily dose. We can't just go, well, let's give her acetaminophen if maybe she's getting it in some other products, or maybe her liver function is also bad. So we need to double check that her liver function before we start treating her with significant amounts of Tylenol or acetaminophen. It is generally a better choice than an NSAID because it doesn't reduce renal blood flow and because it doesn't impact platelets and things like that, or increase that risk of bleeding. It also tends to be better for patients who are medications like warfarin. So let's say Sally's pain increases. Physical therapy came to work with her, and now she's saying her pain's a 9 out of 10. And let's go back to her order set, and she's got PRN orders for, again, the same 3 medications, acetaminophen, ibuprofen, and morphine. What do we give her? Well, morphine is our prototype opioid. Other opioids share many of the same characteristics, but they don't reduce inflammation. Rather, they change how pain signals are transmitted and perceived within the central nervous system. So we'll take a look at that. So with every opioid pain medication, we want to ask the same question. Is it safe to give her this medication? And it might be. We want to assess her pain, her respiratory rate, her level of consciousness, her level of sedation, her blood pressure, and her previous response to opioids. And we also remember her kidneys. So to understand how opioids work, I've created this slide for you here. Opioids don't reduce inflammation, and they don't treat the underlying cause of pain. Instead, they bind primarily to the mu-opioid receptors in the brain and the spinal cord, decreasing pain transmission and changing how the brain perceives and responds to that pain. They basically shut the gate to reduce the pain signal from reaching your brain. And the cause of the pain, it's still there. It just doesn't get noticed as much. It's like if you got your hand on a hot iron. We haven't taken the iron away. It's still burning your skin. We just told you not to care about it. That makes sense. So you don't notice it as much. But here's an important nursing connection. Opioid receptors aren't involved only in pain. They also depress activity within the central nervous system and the respiratory center in the brain and slow the GI tract. And that's why our clinical goal is a balancing act. It's to provide some effective pain relief without causing excessive sedation or respiratory depression, while also anticipating these effects and common effects like constipation. So when you think opioid, I want you to think pain relief, but I also want you to think CNS depression and do a respiratory assessment. And I also want you to think of constipation. There's oftentimes where we have little old ladies who have chronic back pain and they're on opioids and they come in really constipated and they don't know that their opioid medication is what's been giving them constipation. So we're going to talk about that in just a moment. Our archetype drug for this class of opioids is morphine, and you can identify its relatives by looking at names containing morphone, like hydromorphone, or codeine, like oxycodone, or roots with phent, like fentanyl. Now pay close attention to a high-yield safety trap that Saunders often flags, and it's this. Hydromorphone and morphine, though they sound the same, they are really different. Hydromorphone or Dilaudid is roughly 7 times stronger via IV than morphine. And so if an order calls for 2 milligrams of morphine and you accidentally give 2 milligrams of hydromorphone, you've just given basically 14 milligram equivalent of morphine to your patient and you could kill him. So you always want to double check your labels and do those 6 rights of medication. Make sure you got that right drug and check it, the order, check it at the Pyxis and check it before you give it. Make sure you're giving it to the right patient. And you always want to assess. So morphine works by activating the mu receptors. It provides analgesia and sedation plus respiratory depression and slow GI motility. I created this slide mostly just to illustrate differences, not for clinical decision making, but I wanted to include loperamide. Loperamide is an opioid. It was actually designed, it was an attempt to be a new medication to treat pain, a new opioid medication, but it didn't treat pain at all. It made people constipated. And so they use it as a great drug for treating diarrhea. It's the effective ingredient in Imodium AD. But it doesn't cross the blood-brain barrier, so it has no effect on the central nervous system as far as pain goes. There's codeine, which is very weak in comparative relationship to morphine, and you'll see it like with Tylenol with codeine, or it's useful as an antitussive to help with the cough center too. There's hydrocodone, there's oxycodone, there's hydromorphone or Dilaudid, and then there's fentanyl, which is a synthetic opioid. As opioids suppress the central nervous system, your absolute danger zone is really in the area of sedation and respiratory depression. And so you must count the patient's respiratory rate for a full minute before giving any opioid according to Saunders. And if that respiratory rate is less than 12 breaths per minute, you don't give the drug. You hold the dose, you try to stimulate the patient to take some deep breaths, and you call the provider. But beyond breathing, the rest of the body, opioids can completely paralyze GI motility, causing severe constipation. And remember this core rationale: tolerance never develops to opioid constipation. It just, yeah. So patient will need a standing order for a stool softener and a stimulant laxative the entire time they're on therapy, or something. It could be additional fiber or fluids or exercise. They can also experience orthostatic hypotension, so you want to teach them to dangle their legs at the bedside before standing up to prevent falls, or you're going to be having to do some additional paperwork that you don't want and they don't want. So let's do a little bit of retrieval practice. We go into Sally's room and she is completely unresponsive to your voice. Her pupils are the size of tiny pinpoints and her respiratory rate is only 6 breaths per minute. So 2 questions for you, and you can pause this if you want to think about it. What classical phenomenon is Sally exhibiting? And what are your immediate nursing priorities? And what reversal medications do you anticipate giving? You can think about that. You can pause this if you'd like. So Sally is having an opioid overdose, and there's a toxicity triad there of respiratory depression, pinpoint pupils, and coma. And to remind you of pinpoint pupils, I like to spell the word opioids, like you can see that in the bottom corner there, with 2 little dots over the eyes. And so when you see the word opioids with the 2 little pinpoint pupils, I want you to think about that, opioids. And then you can, and you got coma. And so the primary antagonist that we use for this is Narcan or naloxone. It basically functions as like a linebacker, if you can think about it. It is this really has this huge affinity for the mu receptors and the opioid receptors in the central nervous system, and it more so than the opioid itself, and it just pushes them out of the way. It's just like this big guy just shoves them out of the way, and you get pretty instant results. And sometimes you get a really pissed off patient because they were having a really nice buzz, and we just saved their life, but now they're pissed because all their pain just came back and they're having some really bad withdrawal effects. But this is the really important thing about Narcan. It doesn't last long. It has a pretty short half-life. It's only about 30 to 90 minutes, somewhere in there. And some morphine opioids can stay in your system for hours, which means if you give a medication that cleans off the receptors, but it stops working after maybe an hour later, all that opioid is still in the system, and it can cause a repeat overdose. And so you got to keep reassessing your patient, because your patient can end up going back into respiratory arrest. So you want to continue to monitor that patient's breathing and repeat giving them doses of naloxone as needed. Also, naloxone won't hurt a patient if there's a thought that they might be having an overdose. You can just go ahead and give it. A lot of times EMS or police officers will, if they suspect an arrest, but it's not going to hurt them if they don't have an arrest going on. So some patient teaching around opioids. Avoid alcohol and other CNS depressants. You don't want to mix these medications and alcohol together, because you're just asking for a respiratory depression and possibly death. You want to prevent constipation, so it's going to be like fiber, exercise, water, stool softener. You want to avoid driving if that's appropriate. You want to store them safely to prevent misuse. Kids get into these, family members can get into these things and get into grandma's opioid stash. And consider other less addictive options that treat the cause of the pain first. Remember, morphine and opioids only block the sensation of pain. They don't actually treat the cause, and we want to try to treat the appropriate cause of that pain. So there's opioid use disorder, and this is a final issue nurses need to understand on opioids, and that the patient with opioid use disorder may still experience significant acute pain, and they deserve appropriate assessment and treatment. Having opioid tolerance may mean that the patient's response to standard doses is different, and suddenly stopping opioids can precipitate a withdrawal. I had a patient in the ER whose equivalent amount of morphine that they were receiving was in the area of 45 milligrams a day because he had been on opioids for so long. That's an example of tolerance, significant level of tolerance. And he couldn't get a hold of his pain management doc because their pain management doc was out of town, and he was out of his script, and he was going through some wicked withdrawals. And so our job is not to decide whether or not someone deserves pain medication. Our job is to assess, advocate, and administer safely and support their recovery. Evidence-based medications used to treat opioid use disorder include methadone, buprenorphine, and naltrexone. So tolerance doesn't equal addiction. Physical dependence doesn't equal addiction. And a history of opioid use disorder does not mean a patient doesn't have pain. So we want to advocate for these patients, watch for withdrawal, recognize tolerance, and try to get them the support that they need. Not all pain responds to traditional analgesics. Neuropathic pain, often described as burning, shooting, tingling, electric, that comes from damaged or irritated nerves sometimes. Medications such as gabapentin, pregabalin, and duloxetine can help quiet that abnormal nerve signaling and reduce neuropathic pain. And the clinical pearl here is pretty simple, and that's to recognize the type of pain before choosing the medication. And so you want to do the assessment for the physician or the healthcare provider. They should be doing their own assessments anyway, but you can assess it. You said that OPQRST way of assessing it, and recognize the type of pain before choosing that medication. Corticosteroids like prednisone are also powerful anti-inflammatory medications, and they can serve as co-analgesics when inflammation contributes significantly to the pain. They suppress inflammatory and immune responses, which explains both their benefit and the risks. And when you think of risk, I want you to think of infection and hyperglycemia as the major nursing concerns. With longer therapy, remember that corticosteroids generally should not be stopped abruptly because the body's natural cortisol production levels may be suppressed. A key connection here is less inflammation means less pain, but immune suppression and things like hyperglycemia can come with the cost. Never stop using them long-term abruptly. We talked about inflammation and NSAIDs and acute pain and opioids, but there are other types of pain medications I want to mention here. And that's because not every type of pain is going to respond to the same tool. And severe pain doesn't simply mean more opioids. I don't think you need to know all of these for the NCLEX, but I want you to know that they exist in your clinical toolbox so that you have a mental folder for it. And this comes kind of under the umbrella of multimodal pain management, which is often a combination of medications because they can be better than a single medication at treating and controlling pain because we're hitting various pathways to treat that pain. So consider Excedrin migraine. It typically works better than just the Tylenol because it has aspirin, acetaminophen, and caffeine in it. That's a good example of multimodal pain medication. But for painful muscle spasms, you might use a muscle relaxant medication like baclofen or methocarbamol, which is brand name Roboxin, and that might help reduce bronchospasms. The nursing concern here is many muscle relaxants cause sedation and dizziness. So think fall risk and think about driving. Patient might have gout, and so they might use colchicine, which treats an acute gout attack. And there's you look at the C's in both of that, C colchicine and a C acute to remember that one. Or allopurinol, which prevents uric acid buildup to help prevent a gout attack. You might think about migraine medications like triptan, like sumatriptan. A lot of people, which is Imitrex, brand name Imitrex. A lot of people will take that for medication. Key thing to know about sumatriptan or Imitrex, and that's if you have an order to give it, and it's not pill form, but in a shot, it's going to be sub-Q, never IV. Don't give it IV. Double check your order set on that because sometimes people will give Imitrex IV, and that's bad That's bad news. You don't want to do that. If it's a sub-Q order, it's a sub-Q order, not an IM order or an IV order. So double check your orders on your triptans. You have things like ketamine, which is MMDA receptor antagonist. And ketamine's just weird, but it works. And low doses, it can provide analgesia through a different pathway. I've given this both IV and IM, and it can cause people to have a weird trip. So I tell them about that ahead of time. And you might have like anesthetics like lidocaine or benzocaine, and you can think specifically of like lidocaine patches or salon pause, and these work by preventing the receptors from firing on the surface level, or they might work a little bit deeper, but typically up in the surface area. There's also things like medicine balls that are filled with lidocaine. It's pretty fascinating. Created this slide so that you would have a single one slide high yield overview. And so you think of symptoms, you think of medication, you can think of something to watch out for. So if they have pain or fever, probably first line would be acetaminophen, and you want to watch the liver. If they're having inflammation, first line is probably going to be an NSAID, and you really want to watch GI bleeding and kidney function. If they're having severe acute pain, you're probably going to be reaching for an opioid, and you want to watch sedation and respiration. If they're having neuropathic pain, you're probably going to be reaching for something like gabapentin or duloxetine, and you want to watch for sedation and falls. If they're having severe inflammation, you probably want to reach for corticosteroids and watch for infection and monitor glucose levels, especially if they're diabetic. So you want to find that right pain type, match it to the right tool, and then anticipate the risks. So let's go back to Sally and look at her orders one last time and the medications that she has for pain control. And she's got PRN, acetaminophen, ibuprofen, and morphine. So it's up to the nurse to pick which one's most appropriate. Which medications concern you now and why? Well, I'm hoping you're thinking a little bit different instead of just going, hey, we're going to give her some acetaminophen, we're going to give her some ibuprofen, we're going to give her some morphine. But with ibuprofen, I want you to think of chronic kidney disease plus previous GI bleed and her asthma history. We probably want to just double check to make sure to see if an NSAID is safe. It would be useful for the inflammation, but it might not be the best medication for her kidneys. With acetaminophen, it's potentially useful, but we need to verify the total dose. Make sure she doesn't have acetaminophen coming in other duplicate products. Ask about her alcohol use and her liver history. With morphine, it's potentially appropriate for severe postoperative pain, but because she has kidney disease, it could mean some greater caution and dosing considerations because it's not going to clear quite so quickly, and also some close monitoring for sedation and respiratory depression. So I've got a few questions here to kind of cover the content, doing some NCLEX style review. Let's say a nurse is assessing a client with diabetic peripheral neuropathy. We see this a lot. The client describes the pain as burning and electric with pins and needles shooting through both feet. What type of pain medication or what type of pain is the client most likely experiencing? Is it nociceptive? Is it inflammatory? Is it neuropathic? Or is it acute? Neuropathic. Why? So neuropathic pain results from damage to abnormal nerve signaling, is commonly described as burning, shooting, tingling, or electric. Nociceptive pain is associated with the activation of pain receptors from a tissue injury, often described as aching, throbbing, or sharp. Inflammatory pain is associated with inflammation, includes swelling and warmth and tenderness. And acute pain describes the duration of the pain rather than its underlying mechanism. The clinical peril here is if it's burning, shooting, tingling, electric, think nerves. If it feels like it's electrical, it might just be electrical. Think nerves. So question 2, it's a select all that apply. A nurse is caring for several clients experiencing pain. Which findings are most consistent with inflammatory pain? Select all that apply. So you think it might be a swollen, warm knee following a recent injury, burning pain in both feet related to diabetic neuropathy, tenderness or redness surrounding an inflamed joint, throbbing pain associated with localized tissue swelling, or electric shock sensation traveling down the leg. You can pause and think about that for a moment. Answers: swollen warm knee following recent injury, tenderness and redness surrounding the inflamed joint, and throbbing pain associated with local tissue swelling. You better not have picked B, otherwise you need to go back and check the previous line. The clinical pearl here is when pain is accompanied with swelling, warmth, redness, tenderness, think about inflammation and not just pain intensity. So clinical judgment application question. So let's say we have a 58-year-old client who reports chronic burning and shooting pain at both feet that has persisted for several years due to diabetic peripheral neuropathy. A client asked the nurse why ibuprofen has not provided significant relief. Which response by the nurse is most appropriate? Go ahead and pause these and read these yourself. All right, the correct answer is ibuprofen because it primarily treats inflammation, but your pain appears to be a result of abnormal nerve signaling. So we would want to give a medication such as gabapentin, pregabalin, or duloxetine for neuropathic pain because ibuprofen is not going to work on that. So they're going to come in, they'll be frustrated, and they'll be in a lot of pain, and they've been taking the wrong medication for it. So we can help with patient education, and if we understand the right kind of pain or what kind of pain it is, then we can direct them to the right kind of medication. So don't choose a medication based only on the pain score. First, you need to ask what kind of pain it is. Let's go to opioid safety priority question. So a nurse is preparing to administer IV morphine to a postoperative client reporting a pain of 8 out of 10. The nurse obtains the following assessment findings: a respiratory rate of 9 breaths per minute. The client's difficult to arouse, an SpO2 of 91% on room air, which isn't super bad in Colorado, but it's not great. Blood pressure of 102/64. What's the nurse's priority action? Administer the morphine, withhold it, administer half the prescribed dose, encourage the client to ambulate. Go ahead, pause, and take your guess. Yeah, the right answer is withhold the morphine and assess the respiratory status. The patient's already showing signs of significant central nervous system involvement and respiratory depression. So avoid administering the morphine because it could worsen that sedation and you could cause a life-threatening respiratory compromise. There you go. The nurse's last question here, and we'll be done. A nurse is reviewing medications for a client who takes acetaminophen, 1,000 milligrams 3 times a day for arthritis. The client also reports taking over-the-counter cold medication containing 650 milligrams of acetaminophen twice daily. Which finding is the nurse's priority concern? A, the client may experience constipation. B, the client is at risk for kidney stones. C, the client may be exceeding recommended daily allowance of acetaminophen. Or D, the client should take both medications with food. Go ahead and pause. The correct answer: client may be exceeding the recommended daily allowance of acetaminophen. The client is taking 3,000 milligrams a day from scheduled acetaminophen plus another 1,300 milligrams a day from the cold medication for a total of 4,300 milligrams a day, and that exceeds the commonly cited daily maximum of 4,000 milligrams. I want to put a caveat in here, and this is one of the reasons for including this question. That's 4,000 milligrams for a healthy person with normal liver function that doesn't drink a lot. So when you have someone with unhealthy liver function or maybe unhealthy, they're alcoholics or something like that, or taking medications that create liver compromise, that total daily dose is going to be less. So we really want to be careful on that. So 4,000 milligrams is usually the absolute ceiling, but oftentimes it can be less depending on your patient. So always add the total acetaminophen amount from every prescription and OTC product that your patient is on, and teach them to do the same, because oftentimes people don't realize this. The same goes for diphenhydramine, by the way. Sometimes people OD themselves on Benadryl because they don't realize that it's in a bunch of different medications that they're taking because they've got cold or flu symptoms. So finally, I hope that you enjoyed today, and I want you only remember three things. I want you to remember these. The first is to treat your patient, not just the pain score. Know that there are different types of medications that you can give depending on what that pain assessment looks like. Number two, always assess your patient before you administer the medication. Know if it's going to be safe for them. Number three, know enough about the mechanism of action for all your medications that you give to be able to anticipate the risk. And four, always reassess your patient after you give them medication. That's just good and safe nursing practice. Thanks for joining me today. I hope it's been a useful use of your time today, and I hope you understand a lot more about how to think through pain medications and how to think like a nurse.